I'm Dr. Tony, and I've spent over a decade in comprehensive dentistry, from orthodontics and implants to restorative and cosmetic care. You'll notice this episode is narrated using AI voice technology. That choice doesn't reduce the quality. In fact, it allows me to dedicate more time to researching, preparing, and delivering the clinical insights that matter most for your practice. Today, we're diving into a subject that's unpredictable and urgent: dental trauma. We'll cover avulsions, luxations, and the immediate interventions that can make the difference between saving a tooth and losing it. This episode is geared toward dental professionals, dentists, endodontists, and emergency responders. But I'll also include insights for office staff on triage and documentation, as well as guidance for patients navigating recovery and the hidden endodontic risks that may surface months or even years later. If you've ever had a patient burst through the door after a high-impact mishap, a fall, a collision, a workplace accident, you know the intensity of these cases. These moments call for evidence-based protocols, quick thinking, and clear communication. These aren't just accidents. They're opportunities to apply precise, evidence-based protocols that can save teeth and prevent long-term complications. Think of it as dental triage meets high-stakes puzzle solving, where every minute counts and your decisions ripple into the patient's occlusal future. We'll break this down methodically, starting with the foundational classification system. Then we'll move into specific injury types, management strategies in a private office, patient instructions, potential pitfalls, and follow-up care. Let's get into it. Andreasen Classification. First, let's ground ourselves in the Andreasen classification of traumatic dental injuries. Developed by Jens O. Andreasen, this system has been the gold standard since the 1970s. It has evolved to encompass both hard tissue fractures and periodontal injuries. It's not just a list, it's a diagnostic framework that guides our radiographic assessments, treatment planning, and prognosis predictions. The approach divides injuries into those affecting the hard dental tissues and pulp, the periodontal tissues, and supporting bone or gingiva. For today's focus, we'll zero in on luxation injuries and avulsions, but I'll also touch on fractures where they overlap, like enamel dentin pulp involvement. Starting with luxations, these are displacements of the tooth within its socket, disrupting the periodontal ligament fibers and neurovascular bundle. They're classified into 5 main types: concussion, subluxation, extrusive luxation, lateral luxation, and intrusive luxation. Each has its own biomechanical signature, influenced by the direction and force of the trauma. Take concussion first. This is the mildest form where the tooth is tender to percussion, but not displaced or mobile. It's like the periodontal ligament experienced a transient compressive force leading to edema and minor hemorrhage without full rupture of fibers. In a private office, diagnosis relies on a thorough clinical exam. No detectable mobility, but positive sensitivity to percussion or occlusal loading. Radiographs are essential to rule out root fractures. Use periapical views at multiple angulations for comprehensive assessment. Management is conservative. Advise a soft diet for at least a week and schedule serial monitoring of pulp vitality using electric pulp testing, starting at 2 weeks post-injury. For dentists in practice, remember that concussion can sometimes mask subtler vascular compromises. I've adjusted my protocols to include thermal testing alongside electric methods for better sensitivity in detecting early ischemia. Patient instructions here are straightforward but critical. Avoid hard or chewy foods to minimize further stress on the ligament, maintain rigorous oral hygiene with gentle brushing and antimicrobial rinses to prevent secondary bacterial ingress, and return immediately if pain intensifies or swelling develops. Complications: pulp necrosis occurs in a small percentage of cases, often stemming from prolonged ischemia if the initial edema doesn't resolve promptly. Future treatments might include root canal therapy if vitality tests indicate loss of response. Consider incorporating laser Doppler flowmetry in your follow-up arsenal, as it provides a more dynamic measure of pulpal blood flow compared to static tests. Moving to subluxation, the tooth exhibits mobility but no displacement, often accompanied by gingival bleeding that signals partial tearing of the periodontal ligament fibers. This injury involves a more pronounced stretching or partial avulsion of the ligament, creating instability without gross repositioning. In office, if mobility reaches grade 2 or higher, stabilization with a flexible splint is warranted. I'll expand on splinting techniques later. Radiographs should reveal a widened periodontal ligament space, particularly apically. Treatment emphasizes rest, soft diet, non-steroidal anti-inflammatory drugs for symptom control, and vitality monitoring at regular intervals. For patients, apply intermittent ice packs to reduce swelling, use chlorhexidine rinses to manage any gingival lacerations and curb infection risk, and steer clear of contact sports until mobility resolves. Complications include an elevated risk of necrosis, potentially higher than in concussions due to greater fiber disruption, and the possibility of external root resorption if inflammatory mediators linger. Long-term, this could require endodontic intervention or, in severe resorption cases, extraction followed by prosthetic replacement. Now, extrusive luxation. Here the tooth is partially displaced axially out of the socket, often making the crown appear elongated and the incisal edge misaligned with adjacent teeth. This stretches the apical neurovascular bundle significantly, heightening the risk of complete severance if not repositioned swiftly. In a private practice setting, reposition the tooth gently using digital pressure under local anesthesia. Avoid grasping with forceps to prevent enamel fractures or further ligament damage. Follow with splinting for stabilization. Pre- and post-repositioning radiographs are non-negotiable to confirm proper seating and rule out associated root or alveolar fractures. Patient guidance. While immediate self-replantation isn't required since the tooth remains partially attached, seek professional care as soon as possible. Delays exacerbate vascular compromise. Post-procedure, consider prophylactic antibiotics if there's evidence of contamination, adhere to a soft diet, and prioritize hygiene to avoid plaque accumulation around the injured site. Complications are more frequent here, with pulp necrosis rates climbing substantially in mature teeth due to the severed apical vessels, potentially leading to apical periodontitis or cyst formation. Additional future treatments often involve root canal therapy, initiated within 7 to 10 days for closed apex teeth, or apexification procedures for those with immature roots to promote barrier formation. Lateral luxation presents unique challenges. The tooth is displaced sideways, frequently accompanied by a fracture of the alveolar bone, most commonly the buccal cortical plate due to the thinner bone in that region. The tooth may lock into its new position because of the incompressible nature of the crushed socket wall, creating a stable but malpositioned state. Palpation will often reveal buccal or lingual deviation, and percussion elicits a high-pitched metallic sound if bone is involved. In private office management, repositioning requires careful disimpaction. Use elevators or finger pressure to unlock the tooth, then guide it back under anesthesia. Splint for an extended period given the bone fracture. For accurate diagnosis, especially of the cortical plate break, cone beam computed tomography, CBCT, is invaluable. It provides three-dimensional visualization of the fracture lines and extent, far superior to two-dimensional radiographs which might miss subtle buccal involvement. For patients, resist the urge to manually reposition the tooth yourself, as this could worsen the fracture or introduce infection. Apply cold compresses during transit to the office to mitigate swelling. Complications include a high incidence of necrosis from neurovascular disruption, as well as inflammatory root resorption or ankylosis, where the tooth fuses directly to the bone, altering its eruption pattern or complicating future orthodontic movements. Future interventions might encompass prompt endodontics, and in cases of progressive ankylosis, particularly in younger patients' declination, to maintain alveolar ridge height for eventual implant placement. Intrusive luxation. The tooth is forcibly driven deeper into the socket, compressing the periodontal ligament and often crushing the alveolar bone apically. Severity is graded by intrusion depth: mild under 3 mm, moderate 3 to 6 mm, and severe over 6 mm, with greater depths correlating to poor prognoses due to extensive crushing. In a private practice, treatment varies by apex maturity. For immature teeth, monitor for spontaneous re-eruption over 2 to 4 weeks. For mature ones, opt for orthodontic extrusion using light forces or surgical repositioning if re-eruption fails. If repositioned surgically, splint immediately. CBCT again proves essential here for assessing the intrusion extent and any associated root resorption initiators, like damage to the cementum layer. Patience. Seek urgent care without delay and avoid loading the tooth occlusally in the interim. Complications are nearly universal in mature teeth, with necrosis approaching full certainty from the compressive vascular obliteration, alongside risks of replacement resorption or canal space obliteration that can hinder endodontic access. Long-term care typically includes endodontics, possibly combined with surgical crown lengthening if the clinical crown is compromised subgingivally. Now, avulsions. The tooth is completely ejected from the socket, severing the periodontal ligament and neurovascular supply entirely. Prognosis hinges on extraoral time and storage medium. Dry times exceeding 60 minutes drastically reduce periodontal healing potential. Immediate intervention protocols emphasize replantation if the tooth is clean, or storage in balanced salt solutions, milk, or even saliva to preserve ligament cell viability. In office, irrigate the socket with saline to remove clots, replant with gentle pressure, and splint. Radiographs confirm positioning. A variant to highlight: avulsion with associated broken cortical plate. More often buccal given the anatomical thinness of that bone compared to lingual or palatal counterparts. This complicates replantation as the fractured plate may destabilize the socket, leading to poorer primary stability. Diagnosis benefits immensely from CBCT to delineate the fracture morphology, linear versus comminuted, and assess for extension into adjacent structures. Management in private practice involves stabilizing the fracture during replantation, perhaps with sutures if soft tissue is lacerated, and extending splint duration to support bone healing. Patient instructions for avulsions: handle the tooth solely by the crown to avoid damaging root surface cells. Attempt replantation if conditions are sterile, and transport in an appropriate medium while heading to the dentist, ideally within 30 minutes. Post-replantation, systemic antibiotics like doxycycline for adults to combat bacterial invasion, a soft diet, and strict hygiene protocols. Complications include external root resorption, either inflammatory from infection or replacement from delayed healing, and ankylosis or infraocclusion. Future treatments often mandate root canal therapy 7 to 10 days post-replantation for closed apices, or revascularization techniques for open apices to encourage continued root development. Shifting to enamel dentin pulp fracture management, these are complicated crown fractures where the pulp is directly exposed, creating a portal for bacterial contamination. The size of the exposure and elapsed time since injury dictate the inflammatory response within the pulp chamber. In a private office, isolate the field with a rubber dam for asepsis, then perform direct pulp capping with materials like calcium hydroxide or mineral trioxide aggregate for pinpoint exposures. For larger or delayed presentations, employ a partial pulpotomy, removing the superficial 2 mm of inflamed pulp tissue before sealing. Restoration follows with a bonded composite to reestablish form and function. Patience: if the fractured fragment is recoverable, store it in milk or saline for potential reattachment. Seek immediate evaluation to minimize pulpal contamination. Complications arise from untreated exposures, including necrosis and subsequent abscess formation with periapical involvement. Additional treatments may involve full root canal if capping fails, monitored through serial vitality assessments. On splinting techniques, Fiber-reinforced composites stand out for their flexibility and aesthetics, allowing physiologic micromovement that promotes periodontal healing without rigidity-induced ankylosis. Materials like polyethylene fibers embedded in flowable composite are bonded across the labial surfaces, typically from canine to canine for anterior teeth. While some protocols suggest 2 weeks for simpler luxations or avulsions, I usually lean toward 4 weeks of splinting, even in those cases, to ensure robust ligament reattachment and minimize micromotion that could inflame the site, especially when bone involvement is suspected. It's worth noting that dental trauma isn't always recreational. It can stem from occupational hazards, like a construction worker taking a tool impact to the face or a mechanic slipping during a repair. In such scenarios, documenting the work-related nature is key for office staff, as it triggers workers' compensation pathways. Ensuring treatments like splinting or endodontics are covered under the claim, with proper ICD coding for occupational injuries to facilitate reimbursement. For office staff, triage documentation forms the backbone of efficient management. Query the patient on injury mechanism. Was it work-related, perhaps qualifying for workers' compensation? Pain intensity on a 1 to 10 scale, presence of swelling or bleeding, exact time elapsed, and any avulsed fragments brought in. Note allergies and current medications, using standardized templates to prioritize cases like avulsions or suspected cortical plate fractures for immediate dentist intervention. This not only streamlines workflow but also bolsters legal defensibility in compensation disputes. Patients' post-trauma endodontic risks warrant vigilance. Vascular disruption can lead to delayed necrosis, while periodontal damage fosters resorptive processes. Schedule follow-ups every 3 months initially, incorporating vitality testing and radiographs. Watch for discoloration, percussion sensitivity, or radiographic rarefactions. If the trauma was job-induced, leverage workers' compensation for these monitoring visits, as ongoing care often falls under the claim, to prevent secondary complications like chronic apical periodontitis. Wrapping up, dental trauma demands precision. Classify accurately, intervene swiftly, and follow up diligently. These aren't just guidelines. They're lifelines for teeth and for long-term patient health. Thank you for tuning into Smile Sessions with Dr. Tony. In our next episode, we'll focus on workers' compensation in dentistry, what dentists, staff, and patients need to know when injuries happen on the job, and how documentation shapes both care and coverage. Stay dynamic and keep your patients smiling.